How important is an MRI for prostate cancer screening? What is the best MRI technology that you may or may not have access to? How about the radiologist? How good do they need to be when they read an MRI so that they give the right staging of what that suspicious lesion is? Today's conversation is with a professor of radiology. That's Dr. Daniel Margolis, who is a professor of radiology and director of prostate MRI at Weill Cornell Medicine here in New York. He oversees the clinical aspects of prostate magnetic resonance imaging as they relate to the detection and characterization of prostate cancer for targeted biopsy, focal therapy, surgery, and radiation planning. Dr. Margolis collaborates with all physicists at Cornell and have collaborated with physicists and engineers at UCLA and affiliated institutions in development of new and innovative impulse sequences and image post-processing. Dr. Margolis is an expert in MRI imaging. It's so important to have the right person reading these MRIs, and oftentimes, if the right technology is available to you as a patient, the question then is the right person reading it available to you? The person that's most expert, has the highest expertise. And who is that person? How do you find that person? This is the conversation I have with Dr. Dan Margolis from Weill Cornell here in New York. Let's go. Welcome to the Dr. Geo podcast. I am your host, Dr. Geo. As you know, my intention, help you optimize your prostate health, testosterone, erectile function, and as we age, how can we live better and healthier? Today's conversation is with Dr. Daniel Margolis. Margolis, is that a good pronunciation, Dan, of your name? Dr. Margolis. Perfect. We spoke prior to recording. I like to get those things right. It's important to me here. And so, and everyone knows about you from the intro, Dan. So thank you so much, first of all, for being on. I'm a very busy person, and when I'm this busy, I'm thinking, oh, everyone who's coming on are super busy, and so to take time out to do this, I'm truly appreciative of that of your time. So thank
It's
you.
for our patients, so I'm glad to do it.
Dan, you don't get to see many patients.
Yes.
So why? So let's start with this. I always want to know, and I think my audience, I just have a curious mind. So at some time ago, you said, look, I want to go into medicine. And then sometime after you said, oh, this thing of being in this dark room and looking at screens all day and not interacting with patients. Yeah, this is exactly what I want to do. So take us back. What drew you to this, to do what you do?
Well, I'm going to take you back before we were using screens. So
Okay.
I trained at USC for med school in the
Uh-huh.
90s, and I thought that I was going to be a general internist, sort of the regular doctor. And I did a elective in radiology because I thought that would help be
Hmm.
a diagnostic physician.
Hmm.
And the radiologist is the real Dr. House. It's the doctor whose job it is to make the diagnosis. And that's all you do all day long is you're solving all of the medical conundrums to allow all the other physicians to do their job as best they can.
Hmm.
And I just love that. I love the idea that it was all problem solving, it was making a diagnosis, it was showing the path forward for our patients. And I've always been interested in fighting cancer. And as the field has developed, that's become a more and more important part of how we diagnose and manage cancer. And so it was a perfect marriage. I'm very lucky that I was able to find what I think is the best job in the hospital.
So, It's there are a lot of unhappy people who are doing things in their career that they just don't really enjoy and like. So it makes me so happy to hear that, right? I
Mm.
would have been. I'm not a surgeon, as you know, and honestly, early on in my career, I said, "Oh man, the lure of being a surgeon, the prestige," and I said, "Man, did I choose the wrong thing?" And I was a little bit regretful, and particularly, 20 years ago. Now, holistic medicine is a thing 20 something years ago when I started, honestly, it was a sort of a thing, but in urology, not so much. And it's like soft medicine. Oh, here, take this herb, go meditate. Things that we have so much research on now, and
Yeah.
it's prescriptive. Even
Yeah.
do this much, this exercise, this duration. But back then, it was like soft medicine. I was like, God, I don't want to do soft medicine. Surgeon, I would have been horrible at it, right? I chose the path that I think the calling in terms of the type of medicine that I practice. And so I hear you speaking like that way. I'm like, oh, thank God. Everybody, let's send all our slides to Dr. Margolis. That's what we're doing now. We're sending all our slides, MRI slides there. So I'm glad you do what you do, Dan, and
So am
thank you
I.
for sharing that. You know, MRI has changed the field in prostate cancer. I mean, it's just unbelievable, right? So prior to MRI, certainly even from a diagnostic perspective, right? It's used all the time now and still not in many places. Actually, in most places is not used. But in major institutions is used as a way to target, to do a better biopsy. You can find
Yeah.
things better when you fuse it with an ultrasound.
Hmm.
So I've been saying for a while, man, look, if one needs to have a cancer, maybe prostate cancer is the best one to have. And if there's the best time ever to get prostate cancer, I would think it's now with all the imaging and PSMA scans and MRI and all the technology that's available now. So what is so I get images, MRI images and reports. I really don't know what I'm looking at that well. I've looked at about 100 slides and I'm like, look, you don't want my opinion on what I'm looking at. I still don't know what I'm really looking at. I have an idea, but I look at the report. So I'm banking on your report or whoever is the radiologist. And I'm saying, and I get reports from, when you're at a place, I'm sorry, I'm rambling a little bit, but I'll bring it together. Uh, when you're at a place like NYU, you're at
Hmm.
Weill Cornell, across
Yeah.
the street, you have Sloan Kettering.
Yeah.
Like, am I getting a little snobby here? This is not a 3T MRI. This is a 2T. We need to get the best MRI patient. This is like
Yeah.
kind of thing is like, yeah, you need the best. So, what are we looking for? What kind of equipment are we looking for? Am I being snobby or at this point, if you don't have a 3T MRI, then, maybe the patient should try to find one. Or if they can't, then how useful is a 2T? Or I don't even know if there's such thing as a 1T anymore. So
Yeah.
take us back. Tell us what that actually means
Hmm.
from a physics perspective.
Yeah.
And is it important to get a 3T if you can?
So that's a great question. 3 Tesla, or that's what the T stands for, is Tesla, which is
Mhm.
a measure of the magnetic field. It's how powerful is that magnetic field. And it's, many thousands of times more powerful than the Earth. Otherwise, we wouldn't be able to get any information out of it.
Mhm.
So it's a very powerful magnet. And the strength of the magnet gives you clearer pictures. It gives you more signal, or the ratio of signal to noise. And that's the simplest measure to determine in terms of the quality of the magnet.
Mm.
There's another thing called gradient field strength, which is how fast can you switch the magnet field to actually generate the images. And that's much harder to figure out. It
Mm.
can also change depending on the software version. And so we don't really try to standardize on the gradient strength, although I would much rather have a 1.5 Tesla. So the two strengths out there are 1.5 Tesla and 3. I'd much rather have a 1.5 Tesla magnet with modern gradient field strength, or gradient switching ability, than a first generation 3 Tesla magnet, which is very powerful but doesn't have the new software that we use to generate the best quality images. So It's not as straightforward as it has to be 3 Tesla, but obviously if I can get 3 Tesla, I will. Now,
Mm,
some patients can't get a 3 Tesla
right.
MRI.
Some
Um,
cannot get a let's just many cannot even get an MRI,
yeah,
even in the United States, certainly globally, it's
yeah.
just not available. It's just very expensive.
It's expensive and sometimes it's potentially very dangerous. So
Mm,
there are some implanted electronic devices which can't tolerate the MRI. It will trigger them, and at best it breaks, and at worst it causes a shock that stops the heart working. So if a patient has an implanted electronic device, it's crucial to let the imaging center know what device it is. And some
eh,
a pacemaker is a good example. And that's the most common thing that we see. Now, many of them are compatible with MRI. And some of them we can do 3 Tesla. Some of them are only okay at 1.5 Tesla. Some of them will also have other limitations, such as how fast we switch the gradients. So it can actually limit the gradient field strength. And we are used to this, so we have workarounds, but it's important that a patient that has an implanted electronic device get the actual device name, or the code for it, because we have a database of all the different devices. So there's more than one pacemaker out there, and we need to know exactly what kind of pacemaker it is. And then there
so
are
let's pause
patients.
there for a second, Dan.
Yeah.
Very important. I've seen many patients with pacemakers,
Yes.
and it used to be at some point, can't remember how far back, I was like, oh, no, that you can get an MRI, period, end of
Exactly. Yeah.
story. Then I don't know when that changed, and I kept saying the same thing, and I was correct. I was like, no, we can now. I was like,
Yeah.
whoa. So patient with a pacemaker,
Hmm.
what are the questions that they need to ask to make sure that they're getting the right MRI, and that if indeed they can get an MRI without any adverse events?
So when scheduling the MRI, the first thing you want to let the imaging center know is that there is this kind of pacemaker. And if there's going to be some imaging centers that say we can't handle it. We don't do any patients with a pacemaker because we're not set up for safety.
Mm,
Obviously, at a center as big as Cornell, we see a lot of pacemakers for prostate MRI, but also cardiac MRI, brain and spine, and so we have a system to evaluate whether the pacemaker is compatible. If it is, then we have to coordinate with our colleagues in cardiology, because there's a setting that they will modify on the pacemaker so that it doesn't trigger while it's in the scanner. So effectively, we monitor the patient, but we turn off the pacemaker. And
mm,
then obviously, when they're done, you need to turn it back on.
mm.
So it
And
may
and
be
then you do this through their cardiologist?
well, we do it through Cornell's cardiologist,
Mhm,
because
mhm,
their cardiologist may not want to come to the hospital. So
mhm.
we have an arrangement with our
Ah,
cardiologist to bring in somebody that can the pacemaker. And most other big centers will have a system where they can do this. Now, when I was working at UCLA, we had a number of sites where we could bring in somebody from cardiology to turn off the pacemaker. At
mm.
Cornell, the only place we can do it is in the hospital, and so that limits our scheduling. So, if you just need a prostate MRI and you have no implanted metal, anything, then almost,
Easy, easy
tomorrow,
peasy.
yeah, within the week, we'll get you scheduled. For a pacemaker, it can take a few weeks, because there's a lot of patients with pacemakers that need scans, but also there's a lot of patients in the hospital that need scans. So we have to budget the time
I see.
for patients with pacemakers.
I see. And as far as the is there so you were mentioning that some technology, and I mean you don't have to get too deep into the weeds, but there's some technology that can take that on, and others MRI technology that it's just not the right technology for someone with a pacemaker. Is that correct?
Exactly. So almost all of the modern scanners, if the pacemaker is compatible, we can modify the scan and it works fine. It works a little better on a modern scanner because we have more options. The other interesting thing is if you have metal implanted, like a hip replacement, even though it's not electronic, it's going to distort the magnetic field. And there are some very old implanted metal devices, especially aneurysm clips in the brain.
Mm,
And those just are not MRI compatible. So, when you think about it, there are things that can be magnetic and you can stick on your fridge. And then there are things that magnet won't stick to. So the
Hmm.
magnet will stick to your fridge, but it won't stick to like money.
Hmm.
And so depending on the composition of the metal, some of it is just fine, and some of it is definitely not safe to be in the magnet. And so even if you, let's say, had a pacemaker but had it removed, there's still wires in there, and we need to know how the wires look and
Mm.
what model it was. The other thing that's kind of ironic is if it's metal in the pelvis near the prostate, we will purposefully choose a low field scanner, 1.5 Tesla over 3 Tesla, because that higher magnetic power means more distortion in the image
Mm.
because of the metal. So the metal actually makes it much worse at high field. And so we've gotten used
Fascinating.
to
So
that.
you have the
Yeah.
privilege. I mean, this is come on. Oh no, you get a 3.0. Oh,
Right.
you have a hip. No, you go to the 1.5. I mean, come on,
Yeah.
isn't it? And this is why I tell people, like a lot of people just cut those that can, obviously, they
Yeah.
come to New York to
Yeah.
get, any of these institutions, while Cornell, I mean, they just NYU, they just come to New York. And I'm assuming that at NYU, I haven't spoken to Dr. Rosenkratz about that, but I'm assuming that we have the same options, right?
Yeah.
1.5,
Yeah.
3.0, depending.
Yeah.
So is everyone, so let's say in a case where there are no metals involved, no hip
Right.
replacements, no metal
Right.
hip replacements, and no pacemakers,
Right.
is everybody just getting a 3T unless they, right? Unless they have, is that how it works?
Yeah. Now, in some parts of the country, there may not be a 3 Tesla available. And one thing that we can do to improve the image quality is using what we call an endorectal coil.
Right.
And that's a little tube that we place in the rectum. It's about the size of your pinky,
Hmm.
but it's got a balloon on it. And so if you see pictures of it on the internet, it looks like it's this huge thing,
Hmm.
and it is once it's inside. And so that's why I used to see all of my patients that got a prostate MRI, because I had the honor of being the one to put the coil in. And fortunately, our technology has improved to the point where we can get images that are better and faster without placing that coil. But for some patients, that's still going to be the best option. And there are some of my very esteemed colleagues, so the chair of radiology at Oregon Health Sciences, he still believes in the coil, and you do get slightly better image quality. We've figured out
With
how
a
to.
1.5. So if you compare the image with a 1.5 with an endorectal coil
Yeah.
versus a 3T without an endorectal coil, is a 3T still better? Or,
So again, it depends on the magnet.
yeah.
I actually have an example of a case where the 1.5 Tesla with the coil looks better than the 3 Tesla. Now, the 3 Tesla image also has a lot of artifact in it from other things. And so it's not really a fair comparison.
Mm,
But
mm.
there are cases where the 1.5 Tesla with an endorectal coil will be better than a 3 Tesla. Generally, it's not enough better that the expense and the discomfort is worth it. So we sort of standardized on 3 Tesla without the coil.
Right. I haven't seen a endorectal coil. It used to be that it was only endorectal coil, if I remember correctly.
Yeah,
Then it's
everything.
like optional. Some were endorectal coil, others are not. And then I haven't seen an endorectal coil in, I don't know,
Yeah.
eight
I don't think we
years. I
have
want to
them
say.
at Cornell. Yeah.
Yeah, exactly. Like, yeah, I haven't seen one of those or a report with someone utilizing endorectal coil in a while. So then the ultimate goal is how can this radiologist have the best image possible to say, yeah, this is very suspicious, this is less suspicious, and we'll talk about how you go about that in a second. But the
Yeah.
ultimate goal is how to get the clearest picture. Many of my patients, as a holistic and integrative practitioner. So I'm the voice, I'm the neutral voice or the good voice for them to kind of give them guidance and tell, no, don't go to that doctor. Don't
Right.
do the
Gadolinium.
gadolinium. I'm always getting tongue twisted with that.
Yeah.
Don't do the contrast. But my goal as a practitioner and who wants, best for their patient is I want them to see things as crispy and clear as possible to make a decision. What's your opinion on the contrast
Yeah.
gadolinium? What's your opinion on that? Have you seen any cases of some reactions? I always say
Yeah,
when they ask me, it's like, look, I don't want the gadolinium because read in the internet that is a toxin in your body and so forth.
right.
I'm saying, I oftentimes say, well, yeah, sure, but your body has a great ability of getting rid of it within a
Yeah,
short period of time. And I just want the best image for the radiologist to see. And I
right.
haven't seen a case, an adverse event ever in my extensive career. And can it be toxic? Yep. I
Yeah,
mean, there was a case last year where some young lady drank a lot too much water. She
yeah,
overhydrated and died. So anything has toxic abilities or
yeah.
abilities to them. So how do you approach these type of conversations on gadolinium? Or is there a specific group that, yep, this group shouldn't
Yeah.
take the contrast? How does that work?
So that's a very important question. And it's something that my field has looked into very carefully, especially because we now know that the gadolinium, so gadolinium is a rare earth element, it's an
Hmm.
atom.
Hmm.
It's kind of like a metal, just like iron is a metal. Um, and it's bound to what we call a chelate, which is just a chemical that binds to metal.
Hmm.
And so the first formulations didn't bind that tightly. And if you give a bunch of the chelate, but the patient has normal kidney function, then it all goes out within a day. And it didn't really matter.
Hmm.
There were cases where patients' kidneys shut down. And we know that ahead of time. It's generally not a surprise because when your kidneys shut down, you get very sick.
Hmm.
But some of these patients needed an MRI. And because that chemical stayed in their system, there's no way to flush it out. Over time, some of these patients got a condition called nephrogenic systemic fibrosis. And this is an extremely rare condition. It's only seen in patients where there is no kidney function at all. And so these are patients that either need dialysis like now or they will need it in the near future.
Mm.
And so it's fairly easy for us to figure out who these patients are.
Mm.
Even so, it was rare, but it was a severe reaction. So the patients would get sort of thickening of the skin and joints.
Mm.
And so it's kind of like an arthritis. Now, because we understand that it has to do with the chemical that binds the gadolinium, we've changed that chemical. And what we use now is something called a macrocyclic chelate, meaning that it binds the gadolinium ion, the metal, on all sides. So there's no place for it to dissociate or leave the chelate. And we haven't seen a case of NSF in the United States for over a decade. I think we're closing up on 2 decades now.
Wow.
And so the current formulations are very safe. There's one specific formulation that's for the liver called gadoxetate disodium under the trade name Eovist, and that is still linear. So it's not a macrocyclic, but because it's excreted by both the kidneys and the liver, as long as one of those organs is working, then it's still very safe. And we've never seen NSF from that agent either. So in
So
terms of
who's using? So should we assume that everyone is using the new formulation, or that's not a good assumption?
no, it's I don't know any site that would incur the risk of the
Right.
older formulations. The newer formulations are the same price, and but they're so much safer that no place is going to. I don't
Okay.
think you can even get the old versions anymore.
So
So it
maybe so if so in situations where the person is healthy liver, healthy kidney, they should
yeah,
probably not worry about contrast.
right.
In
So
situations where they have one kidney
yeah,
and one other kidney removed,
yeah,
with this new formula, probably still the same.
right,
They shouldn't worry about this new about contrast. In
yeah.
situations where they do have compromised kidneys, because of the new formulation, still right, there's still no issues.
Yeah, again, we've been using this in patients with severe kidney failure. So
Hmm.
basically, no kidney function or almost
Mm,
no kidney function. And we haven't seen this condition come back.
excellent.
So the feeling is if you don't need to use contrast, then don't use it. But if it's going to be a benefit, the risk is so low that there's really not a good medical reason to exclude using it. So, for instance, for kidney, or sorry, for gallstones. We see them very well without contrast. So generally, you don't need to use contrast for gallstones. The problem is for the complications of gallstones, you do want contrast.
Right.
And so almost all of our MR scans to look for gallstones do use contrast, unless the only question is, well, we need to know if we need to clean out the duct that connects to the gallbladder to the rest of the body. And in that case, it's we don't need it.
In
For
a prostate
yeah,
cancer scenario,
yes.
it seems like the benefits outweigh the risk by far to use contrast, particularly with this new formula versus not using contrast. And is that right? Is that the correct
So
statement?
that is that's both true and not true, but not for the reason you're thinking.
Okay.
So in terms of safety, I would not hesitate to give contrast because I know that you do get better information.
Okay.
But in terms of whether or not we need that information, there are some really exciting, transformative technical innovations that are very close to being implemented that may make it so that for the initial detection of prostate cancer, we don't need contrast anymore. Now, there are many situations where we do want contrast. So, if there is any risk of a problem with image quality,
Hmm.
then about 1 in 10 cases will have enough of an issue with image quality where that the value of the contrast will allow me to compensate for the problems with the image quality.
Hmm.
So these new exciting powerful scans also require a very uniform magnetic field
Hmm.
and things like rectal motion. So peristalsis is a normal motion of your intestines, and that can compromise it. Also, the rectum's job is to hold things, and those things cause an artifact. So your patients may have had the experience where they schedule an MRI, and the scheduler says, make certain that you empty your rectum before you get your scan. And that is probably the most important thing for image quality. When there is distortion because the rectum is moving, the contrast can actually save the scan. So right now, I still recommend a standard MRI without and with contrast. But I think that in the near future, it's probably going to be reasonable to have a very fast, efficient, non contrast scan with the understanding that there's like a 1 in 10, maybe 1 in 5 chance that the patient may be called back to get contrast.
Wow.
Now,
Are we
this
talking about the, I don't know, 4T? What are we talking about? Like,
oh
do we
no,
need,
we would just call them back to give contrast. So
okay.
we would do them without contrast first, and
But
then each.
that's not related to the technology just being better than what you have now?
So the some of these new powerful imaging techniques are so accurate that the just doesn't add enough more information on top
Oh,
of what we can already get. But it requires a very uniform magnetic field. So I think we will see in the near future in the United States, and especially in places like Canada and Britain that are resource constrained, where they will do these very fast scans that only take 10 minutes. And for 90% of patients that haven't been treated yet, that's fine. Now, in the post treatment phase, contrast is crucial. We need to know what's happening with blood flow because any kind of treatment, whether it's surgery, radiation, focal therapy, even hormone therapy, can alter the prostate such that all these fancy scans are going to fail.
mm,
And contrast is the one thing that will save us. So, my general recommendation is, at least for the time being, if you want to have the most information to get the right plan for your prostate cancer, you should get a scan without and with contrast. But there is a study that's being analyzed as we speak
mm.
that will be revealed at the European Association of Urology next month.
Oh,
And yeah, so they're working on this really hard. I get a lot of emails about this because we're one of
wow.
the sites. And it's seeing just how much information you get from contrast. And so then we will actually know exactly how much value you get from contrast.
I think you know what the answer is on that study, can you, which is not published yet, or you
So,
may have
so
a
no, I'm
hunch.
not.
You may have a
I
hunch.
I have a hunch that the thing is, there's that old saying, there's, liars, damn liars, and statisticians, right? So
Right.
if you want to make the science look the way you want, there's always some scientists out there that can do that for you.
That's
So
right.
I think what we'll see is these centers of excellence with the latest technology and very experienced radiologists that
Mhm,
in the vast majority of cases we don't need contrast.
mhm.
But one, at least for me, one of the cases that I submitted, it did make a difference.
Mm,
So that's that's out of 20 cases. It's only 5% difference.
mm.
But I would not have known which 5% that is without having given the contrast.
It leads me to my next question, Dan, which is, we don't interact with you guys at all. I mean, the patient doesn't. When I say we, and I don't interact even
Yeah,
as a clinician, maybe urologists do, and maybe some urologists do, who need this for their targeted biopsies.
yeah,
But I don't know you. I don't know how experienced you are in reading prostate MRI specifically versus gallbladder versus breast
exactly.
versus right. And so I don't know your experience. So
Mhm.
can I trust if I do a non-contrast MRI that I'll get the right results, the right reading from, and the right results from the radiologist who's reading it? And if not, then should the patient, since there's very little downside, just do contrast because I don't know the person. In other words, the way I've recommended is, look,
Yeah,
at NYU, if you do non-contrast, I'm very confident that I trust our radiologists. But if you're doing in some remote place in the Midwest somewhere, I don't know, nothing against the Midwest, Midwesterns, Westerners, can I trust that person can read it, can read an image, the radiologist without contrast?
so contrast has this advantage that it is very robust, and that
Mm,
term for us means that regardless of whatever else might compromise a study, the contrast almost always works. And so if you know that the study went well and you know the image quality was good and there's nothing wrong with it and you know the radiologist is very experienced, then contrast probably doesn't add as much. But if the radiologist is reading all sorts of scans that day and not focusing on prostate,
mm,
and or it's at a center that maybe doesn't have the very latest scanner, or if whatever you ate didn't want to make its way out by the time you had your scan, then having that contrast may be the thing that makes or breaks the diagnosis.
mm,
So I think for the vast majority of people for now,
mm,
until we've established a validated protocol that doesn't use contrast, it's still in the patient's best interest to get a scan with contrast. I'm
mm.
very hopeful that these new technologies will make it faster and safer without contrast. Because obviously, I mean, it's less expense for us, and
Mhm.
that's one less thing the patient has to go through. We're very close, but we're not there yet.
All right. Well, I look forward to, maybe we'll have to invite you again when things change and give us an update. Actually, look forward to that. How important is it for the radiologist in our world, as it relates to
Mhm.
prostate cancer, to be an expert in reading prostate
Yeah,
MRI images as opposed to everything, right?
yeah.
What are the differences? So how different is it? You don't have to get into details because we wouldn't know. But how is it much different? A gallbladder tumor than a prostate tumor than a liver tumor or
Yeah,
breast tumor? How important is it that this our radiologists are reading prostate images all day, every day?
yes. So I want to say one last thing on contrast.
Yeah,
Some of your patients may be concerned about gadolinium deposition in the brain.
yeah.
That
Oh, good.
is a quantitative phenomenon that we can identify.
Uh-huh.
Obviously, that's very important to us.
Ah,
We've looked at tens of millions of patients that have
mm,
had MRI,
mm,
and the only way to do this is by looking at diagnostic codes. So we can figure out all of the patients in the Medicare database that have had an MRI
mm,
and look at all of the patients to see if they ever got a neurologic diagnostic code or some sort of toxic diagnostic code. That's never happened.
mm.
So
Great.
it
Thank you.
does deposit in the brain,
Hmm.
but there is absolutely no neurological outcome from that. So just like all the other things that exist in the environment that's getting deposited and emit, and your body flushes it out. So we've seen that patients that don't get more contrast, it flushes out. So in terms of expertise, what our current recommendations are is that a radiologist will have read at least 50 prostate MRs with some sort of guidance before they're turned loose in the big wide world. And the college, the professional organization for radiology, has a training program. I have had the great honor of being a teacher at the program,
Specific for prostate.
for prostate MRI. So these hard working radiologists come to the American College of Radiology Learning Center and spend like nearly 36 hours straight reading 100 prostate MRIs.
Mm.
And they come out, very expert. And they go through all the process of a prostate cancer looks very different in the prostate than a liver cancer looks in the liver or a lung cancer looks in the lung. You have to learn a different set of terminology for how to identify what's a prostate cancer. And the benign things and non-cancerous things in the prostate can look very similar if you're not used to it. And so,
Prostatitis, inflammation in the prostate.
exactly, prostatitis, even just what we call BPH or prostatic hyperplasia, which is just there's probably a dietary component to it. So,
I would think there. I would
yes,
think there. I don't want to take the time to talk about that, though I can. But
yes,
absolutely, yes, yes.
yes. So full disclosure, I'm vegan.
Okay,
But yeah, but it makes, and so I take no pleasure looking at these gigantic prostates with all the prostatic hyperplasia that we
right.
think is driven by eating red meat.
Yeah.
Anyway, so but that if you're not used to it, that can look very similar to a cancer if you don't know which features discriminate non-cancerous things from cancerous things. So it does take training. The good news is all of the radiologists that we are training in residency now are seeing tons of prostate MRI.
Mm.
So all the ones that have done a fellowship, meaning additional training in abdominal imaging or abdominal and pelvis imaging, that have done their fellowship are expertly trained to read these things because we read a half dozen every day when we're on
Mm.
the MR rotation.
But they're not required to have this specific certification to be hired at an institution to actually read prostate MRIs. Correct.
Yes. So that's one of the things that we're trying to address at the American College of Radiology. There is a site accreditation for abdominal and pelvic MRI, and there is now a site accreditation for prostate MRI. And that requires having the technological capabilities to do a prostate MRI.
I'm super excited about today's sponsor, which is Mr. Happy XY Vigor, a formulation to enhance testosterone levels and promote sexual function. Mr. Happy XY Vigor, or XYVGGR, was formulated by yours truly to optimize male hormones and free up testosterone and improve sexual health. It also has an abundance of L-citrulline, which helps dilate and open up blood vessels so there's more circulation going into the pelvic area for better erections. Try Mr. Happy XY Vigor today at immrhappy.com/products/XYVGGR.
Also, some of the scans are reviewed by the site accreditors to make certain that they adhere to the quality standards. The people reading it have their education evaluated, and there needs to be a quality assurance mechanism so that the radiologists are getting feedback about what they're saying. And so this is like it's only come online in the past couple months. We don't have it yet. We're still putting together all the paperwork because
Mm.
things don't move quickly at Cornell. But
Yeah, they don't
yeah,
move
or
quickly in medicine.
yeah, in medicine. So this is something that probably you're not going to see in 2024, but by next year, I think it's reasonable to ask, does the site have a accreditation for prostate MRI.
That is, yeah, that is key. That is key because we have to trust, everybody has to trust what we're getting back. And again, I mean, only you guys really know what you're looking at. I know the urologist kind of looks at it and they have more of an idea, but not like radiologists, and certainly everyone else has no idea. I'm just, when patients
Yeah,
bring me discs, because I keep the disc, just give me the
yeah.
report, I have to trust or try to trust the report from the radiologist.
It takes some doing.
So so what can the patient do to get the best imaging possible outside of what you
Yeah.
do, contrast, no contrast? Outside of that, what can they do to be best prepared to get the
Yes.
best imaging possible? How, meals before MRI, how still they need to be,
Hmm.
hydration, anything that they can do to get the best MRI imaging possible.
So the good news is this is a very holistic question.
Hmm.
The
Hmm.
bad news is you're not going to like the answer
Oh.
because what we recommend is a low residue diet, which
Hmm.
means low fiber.
Hmm.
So it's all the things that you want to eat, but
So
you know
eat
you're not
all the
supposed to.
simple carbs you want to eat,
Yeah.
all the cookies and
Yeah.
bread and
Hamburgers, French fries,
right,
but
right,
no kale.
exactly. No kale, no broccoli, right?
And so for the couple days beforehand,
Couple
be,
of days.
yeah,
Wow, okay.
because it as you well know, sometimes things go through in like 8 hours. So like 48 hours is normal transit. Some things will sit around
Yeah,
for a couple days,
right,
and this is the very last part of the digestive tract. So we
right.
need to make certain that everything has gone through. Some sites will actually recommend patients have an enema. Some sites will say, well, maybe just take a suppository or take something that is going to help flush it out. I take a more holistic approach where our schedulers will suggest to patients first the low residue diet. So that is a standard recommendation. Everybody should have a low residue diet for 2 days,
That means a low fiber diet.
low fiber diet.
Hmm.
And then if the patient thinks that it would help to have an enema, just, whatever you get over the counter at the drugstore, that's probably a good idea. The reason why I don't want to go overboard and recommend everybody have it is, as you can imagine, if you do, too rigorous an enema right beforehand, that can cause a lot of inflammation and that actually increases peristalsis.
Hmm.
And so we don't want to inflame the rectum.
Hmm.
We just want to make certain that it's empty. And some patients are, very aware of like, oh, well, then I definitely need to have the scan in the morning because in the morning I know I'm empty,
Hmm.
or, I need to have it after noon because I'm not going to be empty until then. So that's one thing to think about scheduling. And it seems a little not quite safe for dinner table conversation, but that's the most important thing somebody can do to ensure good image quality. The rest is, again, if you have metal implanted in the pelvis or elsewhere in the body, if you have a electronic medical device, if you've had an allergy to contrast, you need to mention that to the schedulers.
Meals
Generally,
before the imaging, not as important.
that's not that important. A lot of centers will recommend being NPO, meaning not having anything
Hmm.
by mouth
Hmm.
except for clear liquids for 2 hours beforehand. And that's just because there's what's called a vagal reaction. So it's not
Hmm.
an allergy, it's just a reaction to having an injection in a vein for the contrast, where patients will get nauseated.
Hmm.
And it's rare. But if there's nothing in the stomach, then that's much less common. And if you just had a big fancy meal of exciting food that you can get in the greatest city on earth, then that's maybe not the best thing to have right before an MRI. So the schedulers are have gotten very good at recommending exactly what to do beforehand and what not to do.
Excellent. How about movement while they're inside the tube, if you will? Movement.
Yeah,
How critical is that? And for the patient that is claustrophobic, what do you do?
yeah. So those are two good questions. You can basically move any part of your body except your hips. you want your hips to be completely motionless
Mhm.
for about half an hour. And the reason is that's when we're acquiring images of the prostate.
Mhm.
And as you probably garnered from what we've been saying, there's not just like one scan that you do and that's it. There's different kinds of scans that look at different components of the prostate. And each of them takes somewhere between 30 seconds to 5 minutes. But you want the prostate to be in the exact same place for all the scans so that we can very easily figure out which thing is which on
Mhm.
each of the scans.
Mhm.
And we can, move the images around so that we can force it to match up, but that makes it a little harder to be absolutely certain of what we're looking at.
Mhm.
So you can move your arms, you can move your head, you need to keep your hips still. Claustrophobia is an important consideration. It's important to know if you think that will be an issue, and also what you think you need to do to accommodate it. So for some patients, they'll get nervous, but if they take an Ativan,
Mhm.
then they're fine.
Mhm.
For other patients, they just can't stand it for more than a few seconds in the scanner. And those patients may need sedation. That's another reason some patients will have the scan in our hospital, not for the cardiologist, but for the anesthesiologist, because they have to be completely sedated. And basically, they're just asleep. They don't have a tube down their throat.
Mhm.
But we don't want to do this in an outpatient setting just in case they have a reaction to
Mhm.
the anesthetic. So we only schedule patients that are severely claustrophobic on our hospital scanner. But for many patients, if they think they're a little bit claustrophobic and they ask their referring doctor, because we don't have this on site, for something to help calm their nerves, that's all they need.
Like an Ativan or
Ativan, or I said Valium once, and I guess there is
yeah.
no more Valium.
Right, exactly. That's what
And
I've
so
noticed as well, yeah.
it makes me seem old when I say Valium.
I tell them to take 10 deep diaphragmatic breaths and meditate for, you know, 10
And
minutes before going in.
so that's a good point. Obviously, I'm a medical doctor. I'm recommending all these drugs. You don't need drugs. We figured this out for our pediatric patients. So you can imagine that being in a scanner can be very scary. And what we used to do is just put them all to sleep, and that uses a lot of drugs, and it's expensive and a little bit dangerous. So now we have child life specialists, and they get the patients comfortable with the
Mm,
idea of being in the scanner, and
mm,
they don't need any drugs, and they have a good experience. And so, if you think you may be claustrophobic and you think you may be able to alleviate this with cognitive behavioral therapy, with hypnotherapy, that's a lot safer than taking an Ativan. It may not
sure,
be as fun, as New
sure.
York City, but if it were up to me, I'd try
In
the
New York City,
hypnotherapy.
right? Our patients, those that meditate and do yoga and things like that, they do it in a stressful way. I don't know if you noticed, Dan. It's like,
I,
yeah, hey, Dan, do me a stop. Don't talking. I'm meditating right now. Jeez. Give me a
I
second.
it,
I'm meditating. It's that kind of thing. Is you're supposed to be calmer when you meditate. I mean,
I took a yoga class on the west side of Los Angeles.
uh-huh.
There's no greater concentration of negative energy than the yoga classes at the fancy gyms in West Los Angeles.
You would expect the opposite, right? It's a very, I've been in natural health for before it came in vogue 25 years. So I've seen how it's progressed and throughout the years. And it's on one end is excellent to see all the science as it relates to mind, body medicine and mindfulness, stress reduction, and all the great research on even so many things, acupuncture, certainly
Hmm.
exercise and things like that. Even
Yeah,
some botanicals, actually good research.
yeah.
But yeah, definitely on the other hand, we've seen such scenarios where it's like this, I've been in, as a quick aside, when I first started getting into this natural health thing, it was 51 now. So it was a 20 over 25 years ago.
Yeah.
So I'm like, holy shit, what I need to figure out what tofu is and tempeh and I don't know any of this stuff. So I said, all right. So I went into naturopathic medical school in my losing track of time, of course. I was in my 28, 27. So before
Yeah.
25, 24, it's like, I need to work in a health food store
Yeah.
because I need to figure this out. I need to know what this is all about. And back then it's not like Whole Foods everywhere in every corner. It
Yeah.
was like the dingy health food store with the black cat sitting on the counter, and it's like all dusty. And I started working in these environments, and I started working in better environments. So I've worked in health food, including Whole Foods, or it was
Hmm.
called Fresh Fields back in the day, bought by Whole Foods. And I
Yeah.
started working and learning about all these things. And honestly, in many of those cases, I saw like unstable people, and people, both customers and even owners of some of these places, like,
Yeah.
this is not too healthy here. I mean, this is something is off here. So I've learned that you could do yoga and even shop in health food stores, which and not be healthy, which it's really helped me appreciate the reality of these things, and how the challenges that come across with just being healthier, and in that process of being healthier. So anyway, as I digress.
That's one of the important things about holistic medicine
Yeah.
is thinking about all the different ways you
Yeah.
can address a
Yeah.
patient's concern. So there's obviously yoga, meditation, there's botanicals, there's Western medicine,
Yeah.
there's other drugs out there,
Yeah.
and understanding the benefits and dangers of each
Yeah.
of these and which works best for that patient
Fan-
is, yeah, is what holistic medicine does for us.
Holistic and integrative medicine. I'm a huge fan, particularly in the world of urology. I've been working in academic institutions for over 20 years, started at Columbia, now at NYU. And look, a, a quick aside, once again, prostatitis, right? So
Yeah,
urologists typically don't do well with this disease. So I take them all on. I love to
yeah.
take care of them. We talk about it, and mind, body, all these things.
Hmm.
There was a case that I had, right, where my eyes is prostatitis. The
Yeah,
case presentation, all the things, right? There's no biomarkers for it, but put him on a protocol, goes home, sends me an email. Look, I'm doing really bad. I'm saying, okay, so go harder on this, whatever I recommended at the time, this supplement, double the dose, maybe. Text calls me, look, I'm doing really bad. I just came out the bathroom and I can't pee, and I'm
yeah,
crying, and my son is seeing me cry, and it's like, this is. I said, look, go see one of my colleagues. Sees Dr. Brucker. He had a urethral stricture. He's had that for maybe over 20 years, and it's
yeah,
gotten worse. And surgical removal,
yeah,
this is a happy person. Here I
yeah,
am thinking prostatitis, go harder, meditate harder. I don't know, deep diaphragmatic breathing, calm your nervous system. And he's like, look, I'm doing all these things.
yeah,
Surgical procedure, urethral stricture taken out, new man, new person. So I truly believe, I believe that Western and Eastern, let's say,
yeah,
they fulfill the deficiencies of the other very nicely. That's,
yeah,
particularly in the world of urology and prostate cancer. And speaking of which,
yeah,
now we went through all that. We have a report. There's a
yeah,
PIRAT score there. So,
yes,
what are let's start with this. The PIRAT score, that's a
yeah,
method of staging, and I don't know if I'm using the right language, where look, a PIRAT 5 is very suspicious. It's not a
yeah,
diagnosis
yeah,
for prostate cancer, but this is very
yeah,
suspicious that we're probably looking at a Gleason 7 or higher.
right,
As you go down that rating system, it goes down to 1 or 0, which is
yeah,
less suspicious. And then you have PIRAT 3, which we're still trying to figure out what
yeah,
that really means in this day and age. And,
yeah,
is it something, I guess it depends on multiple factors. So
yeah.
take us through that process of how you guys determine what's the PIRAT score of a particular image, and what should we do about it? And certainly the layperson, how should they even interpret it?
So there's a statistical method for assessing your concern about something that was developed by a researcher named Likert. And so that's commonly a 1 to 5 category scale. So there's categories go from 1 to 5, where 1 is the least and 5 is the most.
Hmm.
And you can apply this idea to just about anything in statistics, much
Hmm.
less medicine. But it's a way of standardizing your communication. So if you know that somebody's using a Likert scale and they say, oh, it's 2, then well, it's not the least,
Hmm.
but it's definitely not very bad. And that's what we applied to the prostate. There were subjective Likert scales, and those are just called Likert scales, where a radiologist says, yeah, I'm fairly suspicious, but I've seen worse, so it's a 4. Or I can't tell one way or the other, it's a 3. But we wanted to make it more standardized so that if I look at something, I'm likely to give the same PIRADS category as somebody in Timbuktu. And so this was a standardized way to assess each of the components of the MRI and assign it a level of suspicion. And based on where in the prostate the abnormality is, to determine what the overall suspicion is. And so PIRAD stands for Prostate Imaging Reporting and Data Systems. It sounds like a word BIRADS, which is a breast imaging reporting and data system. So that's the first ever Likert score that we used in imaging. And
Mm.
it revolutionized how we diagnose and manage breast cancer. So we thought we can do the same thing for prostate MRI. And so we look at the T2 weighted images. These are sort of the images of anatomy, and they give us a sense of where something is, and a little bit about the suspicion. More importantly, it helps us decide if something is inside the prostate or starting to go outside the prostate or invading some other structure. Then there's what we call diffusion weighted imaging with something called the apparent diffusion coefficient map. So diffusion is a qualitative image that looks at how disordered tissue is on the basis of free water Brownian motion, which is a fancy technical term for is there something that's keeping water from moving freely, or is it moving freely as if it's in a glass of water?
Mhm.
So no restricted diffusion is like a glass of water. Highly restricted diffusion would be like jello, right? So it's very restricted.
Mm.
And so cancers tend to be small cells. They are very disordered, and so they keep water from moving freely. And so that's one way that
They
we
become
identify
more
that
like Jello.
well, no,
Just to
but
just to keep the just to
kind
keep
of,
the
yeah,
analogy
but
going.
the analogy, yeah. So that's where my analogy breaks down. But yes,
Right, right.
so the DWI, the diffusion weighted image, and the ADC, the apparent diffusion coefficient, are kind of ways to confirm that what you're seeing is abnormal diffusion, because there are other things that will be bright on the DWI
Mhm,
and other things that are dark on the ADC.
mhm,
But only truly restricted diffusion is bright on the DWI and dark on the ADC.
mhm,
And the degree to which it's brighter and darker than everything else is what determines that score.
mhm,
So if it's not really abnormal at all, that's a one. If it's a little bit abnormal, but it's kind of diffuse, that's a two. If it's abnormal, but there's things that are worse, that's a three. If it's the worst thing, but it's small, and that's a four. And if it's the worst thing and big, and there's a size cutoff, it's 1.5 centimeters,
mm,
or it's invading something, then that's a five. So that's a very simple way of assessing how abnormal is something on the diffusion weighted imaging. And for contrast is quite simple. Is it enhancing as early or earlier than other structures? So we actually image the prostate every 5 seconds or so, the entire prostate every
mhm,
5 seconds while we inject contrast into a vein. And so the contrast goes through the vein, through the heart, actually through the lungs first and through the heart,
mhm,
and then out to the arteries. And so whatever has a rich arterial supply is going to enhance first. Cancers need a lot of energy. And so they actually create new vessels. It's called neovascularity to help themselves grow.
mhm.
And so cancers are going to enhance earlier than most other things. And so that's how contrast adds value. So it's simple. Is it abnormally enhancing or not? But that's a huge component of how we assess that something is suspicious. And then, depending on whether it's in what we call the peripheral zone, which is the outside of the prostate, or the transition zone, which is the central part of the prostate, we'll look at either the diffusion first or the T2 weighted images first, and then the rest of the components second. And that allows us to come up with the overall PIRADS category.
Oh,
And so one is stone cold normal. It's like a young man's prostate.
mhm,
So
mhm,
there's no abnormality on any of the components. Two is in that component of that part of the prostate, either the peripheral or the transition zone,
mhm,
it's abnormal, but it's not suspiciously abnormal.
mm,
And the reason why we describe it like that is, could it be hiding something? Probably not, but we can't say for certain. We can't be as certain as when the prostate is pristine. And so that's considered low suspicion, but not normal. And technically, a one is very low suspicion because there are very rare cases where we found cancer in a PIRADS 1. Again, it's extremely rare, but it means that we can't say for certain that it's normal. It's just very low suspicion.
Or
So,
very
like,
likely that a Pirate 1 or even a Pirate 2 is a Gleason 6, which we're not really
exactly,
interested in doing much with
exactly.
those. Yeah.
So that's a good thing for us is we're terrible at finding Gleason 6 cancers. So the
Good.
non-aggressive cancers, we're not very good at finding those.
That's good. That's a good
So
thing. Yeah.
that's a feature, not a bug.
Yeah.
So then three is an interesting category from a statistical point of view. It's a terrible category from a patient's point of view
Mhm.
because it means that it's abnormal, but it's not that abnormal. And when we first started doing prostate MRI, nobody had a prostate MRI to look for a target to biopsy. We were using it for surgical planning. So Robert Ryder is a urologist at UCLA, and he and my mentor Stephen Raymond came up with a protocol, and so I was helping with that, and it was very useful for surgical planning. But nobody thought like, well, we can use this to help biopsies. And then Leonard Marks wanted to use it for biopsy planning at UCLA, and my mentor Steve was too busy, and so he assigned me to help out, and so that's how we came up with prostate MRI for biopsy planning. But
Mm.
there's all these men that had cancers for years and they weren't found with a standard biopsy. And so
Mm.
then I could tell Dr. Marks, like, oh, here's a cancer, biopsy that thing, and boom, then we found all these cancers. And so, you know, category 5, 95% likely to be significant cancer. 4, 75% likely. And 3 at the time was about 66% likely. So still, if you saw it, you would be very nervous. Well, then we found all the cancers in these men. And now that we're screening men with greater certainty and we've seen the value of MRI, so we're almost everybody gets an MRI. It's now part of the standard recommendations after an elevated PSA. So the next step is now MRI. So
That took a while.
that took a while.
It was very clear based on the evidence, and of course,
Yeah,
Dr. Tanasia was in the forefront on showing the value of MRIs before
yeah,
biopsying, and the struggle that our office had to go through to get
yeah,
coverage and things. And now, things have changed. Thank God, to that they're
yes.
typically covered.
Yeah, so now it's so much easier to get the MRI. But what it means is a lot of men are getting them with the first even slightly abnormal PSA test.
Mhm.
And so, we're still reading the MRI, and some of these men will have areas where it's not clearly normal, but not clearly abnormal. So that's a PIRADS 3. And so now we looked at a number of sites all across the country. All of them were experienced in reading prostate MRI, but obviously the screening frequency, the populations, the biopsy skill, and the radiology skill is going to be a little different from site to
Mhm.
site.
Mhm.
And there's a lot of variation where in some sites, a PIRADS 3 may only be 20% likely to have a significant cancer. In other sites, it was, still up to 66% likely.
Mm.
So what the it's clear that a PIRADS 4 or 5 is suspicious enough that you should biopsy that. And in fact, if you have a PIRADS 5 and the biopsy comes back negative, meaning no cancer at all, it's fair to ask the urologist to contact the radiologist and see if the thing that was biopsied was the same thing that the radiologist found.
Mhm.
And sometimes the radiologist will say, oh, no, that's actually an abnormal BPH nodule. So it's very suspicious, but now I can tell, since I know that it's probably not cancer, that there is a feature that, was obscured on, these other images that, now I can tell that it was actually benign. Or sometimes they're like, no, that, or there's another condition called granulomatous prostatitis, which is an inflammatory condition
Mhm.
that people can get. And that has a somewhat characteristic appearance, but it always starts out looking like cancer. And if it comes back negative, then what we will often do is ask the pathologist, okay, there's no cancer. Did you see granulomatous prostatitis? And sometimes they will say, well, yeah, of course. I mean, but it's not cancer. Why would I tell you that? You don't need to
Mm.
know that. I'm like, yes, we need to know that now. So for a 5 that comes back negative, it's worth a second look to see if you can explain why it was a negative 5.
It's not a
Um,
blaming game. Well, you
it's
didn't biopsy in the right place. Well, you gave me the wrong reading. Is that not?
it,
Hopefully, we
it's
hope it's
part
not a
of
blaming
yeah.
game and it's all
It
cordial.
It's part of the medical process. And then for a 3, the simplest answer is in an experience center, your radiologist is unlikely to call a 3 if there's not at least a 25% likelihood that there's cancer. And that's high enough that you don't want to ignore that. But what some sites will do is look at other parameters. So there are blood tests that can give you a sense of what's the overall likelihood.
Yep.
And in somebody that really wants to avoid biopsy, maybe there's a number of other health conditions that are more concerning, it's worthwhile to consider one of these other tests. Now, the other test that's coming down the pipeline that's very exciting, AI.
Yeah.
So artificial intelligence can be applied to digital images like radiology. And so I have colleagues at Cornell that are working on what they call a saliency map, which sounds great, but it's basically a cancer probability map of the prostate. And we need a lot of data to develop these models. And we're going to need a lot more data to make certain that the model will work on some other patient's MRI. So, if we develop the model for all the MRIs at Cornell, we use the same protocol for all of our patients. Does that mean it's going to work at NYU, where they've got a bunch of fancy scans that, Andy Rosenkrantz and Angela Tong, my colleagues there, are doing? Maybe, but we're going to need the data to figure that out. But pretty soon, we'll have that data, and it won't only tell us like where we think the cancer is, what's the overall likelihood that it is significant cancer? And so that's one of the very exciting
It
things
will
that
reduce the amount of human error.
it will. So it'll give us a better target,
Yeah.
and it will give us a greater degree of certainty. Can we safely avoid biopsy in this person? And that's going to, help a lot of men's confidence in their practitioner. It will also save money, be safer. So, as much as AI seems to be having slip ups right now, I think when it's applied in a rigorous and careful manner to medical images, it has tremendous potential to make your radiologist that much more worthwhile.
I was having a conversation literally earlier in a recording, and maybe this would be published. That recording will be published before yours with Dr. Dan Spratt, who is
Yeah,
from Case Western, a
yeah,
radiologist oncologist, and he wrote the paper on New England Journal on AI, Atira AI. So I had him
yeah,
on,
yeah,
and I mean, it's exciting. I mean, these are type of things you could to determine. Yeah, this patient can utilize hormone therapy, but this group
yeah.
of patients, don't need it. They won't do better from it. And these type of things that we talked about, all things AI. What does the future look like? And one of the concerns I'm always thinking of you guys like,
Yeah.
well, is AI going to replace Dr. Margolis? And the general consensus is just like Chat GPT is a tool. It
Yeah,
doesn't or it shouldn't replace too many people or writers.
yeah.
Is a tool. So the general consensus at this point is that AI will be a tool for you as well. So what are your views on the future of AI in images and radiology?
So there's a really great quote, and I wish I could attribute it correctly,
Hmm.
that AI is not going to replace radiologists, but radiologists who use AI are going to replace radiologists that don't.
Yeah, right, right.
It's becoming a very valuable tool for
If
us.
you're not using emails at this point, there's not much you can do in this world.
Exactly.
Yeah,
So
yeah,
it's a
that kind of
tool,
yeah.
and you don't have to be a radiologist to use it, but you have to have the experience of a radiologist to know when to use it
Hmm.
and how to use it.
Hmm.
And because we're the ones developing these tools, we're at the forefront of understanding how to use them.
Hmm.
Now, will it mean that I can, do my work faster and we may not need as many radiologists because get more efficient? It'll generate the report for me so I don't have to spend a lot of time spell checking. Yes, it will make me a more efficient radiologist, and we may need fewer radiologists in the future. On the other hand, it's going to make me much more valuable to our patients. You can imagine that if a patient can get an MRI and know not just, do I need a biopsy now, but do I need a biopsy ever? That's coming,
100%.
and that's going to make me that much more valuable to the patient. That's what I'm hoping that I can do with AI.
What's your best predicament when this type of technology will be available to you?
So it's going to come in bits and spurts.
Mm.
The good news is the FDA keeps us safe. The bad news is they work very hard to keep us safe.
Yeah.
So I have,
Yeah, right.
we've heard about drugs that get released too quickly.
Yeah.
And I think the resistance that the FDA has to just turning things loose willy nilly is valid. And it keeps our patients safe because I've seen
Yeah.
studies where what they're studying doesn't work as promised.
Right.
But we'll see it used first to aid the radiologist in finding things. So it's detection support and then eventually decision support. So do you call this suspicious or not, and then generating the entire report, but that's going to come slowly, and then finally as a biomarker, for meaning a detection tool to guide the entire patient management. That will come, but it's going to take so much data to apply the algorithm to figure this out. That's at least 5 years away,
Mhm.
maybe even 10.
Wow, longer than I thought.
But new things are coming. There are some AI tools that are already approved.
Yeah, we're just waiting for
So
the FDA to approve at this point, and
no,
and
some of them are FDA approved.
and
Um,
so it's not part of the guidelines yet, or
no,
NCCN guidelines, or
they're so right now they are useful for aiding a radiologist in finding things. And what it's found is for somebody that has a lot of experience, it slows us down, right? Because then we
mm,
have to look at one more thing and it won't
mm,
change what we say. But for somebody who's starting out and for our trainees, it can be very helpful because it's like another radiologist that
mm.
may have some experience to say, well, I think it might be this thing, or
Kind of
I don't.
confirm what you thought, what the radiologist thinks.
Yeah, I give you a sense of like, one or two areas to scrutinize one more time. So those are out there. There are newer tools coming. There was actually a group in England that I saw at a meeting that I'm talking to try out their software. Again, there's a good chance that it may not improve on somebody who has a lot of experience, but it's worth a try.
Lovely. I guess my last question, Dan, is the following. I'm a patient, and I got this MRI somewhere in Oklahoma.
Mhm.
Nothing against the Sooners or Oklahoma or anyone there, but I don't know that they have high volume. I don't know that I can trust what the radiologist
Yeah.
read. I want to send this for a second opinion. What do I do with these slides? Where do I send it to?
That's a great question. So I'm from Southern California, but my mother is from the Texas Panhandle, and I have
Okay.
family that lives in a small town no one's ever heard of. I think it has a stop sign, so
It's
it's
not completely third world. Good.
it's Texas. So the closest MRI scanner is 50 miles away,
Mm,
and that's like one scanner for all of the Panhandle.
mm,
And then
mm,
there's Amarillo's going to have a bigger scan, but Amarillo's not nearby, so
mm,
that's like the
mm,
closest big town. That's not a big town. So a lot of our countrymen are not going to live near, NYU, Sloan Kettering, Cornell.
mhm,
And whether you can get a second opinion is going to depend on where you want to send those images. So Cornell does not currently have a program. We're actually talking to our colleagues in pathology that do have a program to see if we can basically borrow what they do.
mhm,
Depending on your urologist and who you see, very often they have an agreement with their hospital system to have scans overread there. So if you are thinking of being treated by a urologist somewhere else, that urologist will probably want those scans and
mhm,
may have their local radiologist overread them, especially if they have experience. So
mhm,
that happens, at NYU, at Cornell, Sloan Kettering.
mhm,
And then there is a possibility for some institutions to get an official second opinion. Those generally cost some amount of money. And technically, you do need a physician's order to do that. But technically, I'm a physician, so I could order it. Insurance often will not pay for it.
mhm.
And so it's not always inexpensive. But I think it's reasonable. The most important person is the physician who's managing your care. So not everybody has a Dr. Geo to help them
Mhm.
through the pathway to find the right person.
Navigate
Um,
navigate the process, right?
Navigate, yeah, patient navigation. But if you have a urologist or even just a general practitioner, an internist, a family physician that you trust, ask that person, where do they think you should get the scan, and who else should you see? And maybe if they say, oh, well, I don't treat a lot of prostate cancer, but here's my colleague that does, ask that person first. Maybe she has a better idea about,
Mhm.
where she wants you to get the scan.
Lovely. Wow, you've been extremely generous, not only with your time, but with the amount of information you shared with me and our audience. So, Dan, thank you so much. Parting words, if you have any. And I was going to say, if people want to get in touch with you, I don't know exactly for what, since you don't see
Yeah.
patients, but feel free to provide a way if that's something that you find it useful for the audience.
So what I found is my colleagues at Cornell in the scheduling office, they know where I am better than I do. So if you call Cornell Radiology,
Yeah.
the official name is Weill Cornell Imaging at New York Presbyterian. They can find me. I think the
But
future,
you cannot, to be clear, you cannot read anyone's slides unless you're a patient of a physician at Cornell at this point in
exactly.
time.
So currently Cornell only has a system to overread scans for patients of a Cornell physician. So
Yeah,
urologist, radiation oncologist, internist, but only for Cornell physicians currently.
got it. Hmm.
I Again, the most important thing for a patient is to find a physician they trust, and a physician who is experienced in the condition that is of concern. So in this case, if you're lucky to have a Dr. Geo,
Hmm.
help you navigate through the system, then that's great. If you have a urologist or radiation oncologist, or just an internist or medical oncologist that will help you navigate the system, that's the most important thing. And for prostate MRI, the radiologist is an important part of it. So you want to find a center that does a fair number of prostate MRIs and has a relationship with their referrers where they're getting feedback about, which patients turned out to be positive and which ones were negative, because that's an important part of that radiologist being able to optimize their reading.
How would they know, Dan? So, what question? Who are they asking? These questions, and how would they know? Is there a website? Was it, well, these are the most accredited radiologists for prostate cancer?
So, again, the American College of Radiology has that Center of Excellence in
Right.
Prostate MRI
Not required
accreditation.
yet, but
Right,
maybe it
not
will be.
required, but you can ask. But then ask your, let's say, urologist,
Mhm,
does your radiologist have access to the pathology reports? And do you know if they look at them?
mhm.
And if they say, yeah, they have access, I think they look at them, yeah, I've talked to them about it, that's good. If they have a standardized system that, I'll be honest, Cornell is still working on. We have a meeting where we meet once a month to go over cases,
Mhm,
but we're working on AI to figure out, exactly what our optimized reading pattern is.
mhm.
But if they're like, well, I don't know, I guess some radiologist might be able to get the reports, but I never send them to, that's a red flag.
Yeah. Okay, that's good. That's actually very good. Or I always say, who wants to talk negatively or imply negative things about their institution or their practice? No one. So I always say, look, when the urologist, and I love urology, love these surgeons, they are amazing what they do. It's the most unbelievable thing that they take out this prostate and people are functioning again in days.
Yeah,
I tell
yeah,
people, listen, I'm not a fan. I don't want anything taken out of my body. I don't want even a biopsy. I don't want anything. But I tell
right.
you, if you need it, these people do magic. They're so skillful now with the robot and everything. That said, I tell them, look, but whatever. No, how many have you done? Always knock that down by
Yeah,
20, 30%, right? It's just, sometimes it's a natural bias, even, and is an
yeah.
innate bias, that comes with the territory. Dan, again, thank you so much for being on. I tell you, this is going to be a hit. So thank you very much, and we'll have you again once there's another new information on AI and radiology and so forth. So we'll have you again. Thanks for being on.
I look forward to it. Thank you so much.
Thank you. All right, everyone. Thank you so much for listening. Again, we bring the goods every single time. Dr. Geo podcast here. If you have any questions, always on the comment section, particularly of the YouTube channel. All other things are drgeo.com. And thanks again for listening. Stay well, and I'll see you next time. Dr. Geo here, signing off. Talk to you soon. Thanks for tuning in to this week's episode of the Dr. Geo podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Geo Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.